All right, so we are learning appendicular skeleton. Okay. Appendicular skeleton, let me insert a slide right here. So once again, I'm not going to go over every long bone. Okay. So we went over, again, a quick review. Axial skeleton is along the axis of the body, skull, rib cage, hyoid bone. Appendicular skeleton are the structures, bony structures that attach the extremities to the axial skeleton. So pectoral girdle, bones of the upper extremity, pelvic girdle, which is what we are going to be studying today, and bones of the lower extremity. All of these fall under appendicular skeleton. So we went over pectoral girdle last class, and we went over the bones of upper extremity. Let's go over pelvic girdle today and the bones of the lower extremity, out of which some bones are to be honest, very straightforward. Okay. So pelvic girdle. Pelvic girdle, basically this is fusion of three bones. Okay. And it's probably the most complex bone in a way, because pelvic girdle doesn't have a, what should I say, like a well-established or rather well-visible. It's not, doesn't have a simple anterior posterior. It's slightly twisted bone. So pelvic girdle also known as ossa coxa. Ossa coxa, I don't know if you can read the writings here. It's a Shutterstock image, so it's not the great quality, but these are also images that don't have any copyright. So ossa coxa or os coxae. Ossa coxa, what does it mean by ossa coxa? So what you are looking at here, you are looking at the sacrum, of course, and ossa coxa refers to the left and right components of the pelvic girdle. So this is the right component, that's the left, not your left, your right, the skeleton's left, the skeleton's right. So this right and left components together, what makes pelvic girdle, are together referred to as ossa coxa. If you are referring to only one, say either the right or the left, you can call that os coxae. Okay. So each os coxae is made of three bones, and these three bones are fused. But you can arbitrarily identify, well, not arbitrarily, somewhat clearly identify. One of them is, two of them are easily identifiable. These three bones are basically what we call the ilium, ischium, and pubis. Ilium, ischium, pubis. So each os coccyx is made of ilium, ischium, pubis. Just by looking at this, which one is ilium, which one is ischium, and which one is pubis. Okay. For that, ilium is the largest bone that makes up the superior portion of the os coccyx. This is how it articulates with the sacrum. Okay. Now the inferior, use a different color here. The inferior portion here. Out of the inferior portion, you can think of it almost arbitrarily half and half. Half of it is made by pubis, half of it is made by ischium. Okay. So ilium, ischium, pubis. First thing you want to identify, and this is for reference, or something else that you also want to keep in mind, that ilium articulates with the sacrum. This is called the sacroiliac joint. So ilium articulates with the sacrum. Pubis, each pubis of each os coccyx articulates with one another via a cartilaginous disc. This cartilaginous disc, this is what we refer to as pubic symphysis. It's not on your, actually yes, it is on your list. So pubic symphysis. We want to identify the pubic symphysis because that basically gives you the orientation of the ilium, pubis, and ischium. Okay. Something else, just like for scapula, we looked at the glenoid fossa. You want to identify this foramen, this large foramen that's here. This foramen is referred to as obturator foramen. Obturator foramen. And a third identifying factor is acetabulum, but that's not clear when you are looking at these two ossa coxa from the anterior view. So let's change and then look at a single os coxa here. So ilium, pubis, ischium, obturator foramen, pubic symphysis. The pubic symphysis, basically, this gives away how the bone will be present within the human body. So let's look at this. So ilium, how do you know which one is pubic, which one is ischium? For that, again, this surface that we are looking at, this is where the pubic symphysis will be. So this is the pubic symphysis surface. Pubic symphysis. Once you identify that, then the anterior, posterior start making sense. The sacrum end is the posterior, the other end toward the obturator foramen is the anterior. So we can arbitrarily draw the line here. This would be pubis. This would be ischium. Obturator foramen, of course, we learned that. Now here it is. This is the lateral. So basically, this is rotated so that this is the lateral side. This large depression, this is known as acetabulum. Acetabulum. Okay. So just like glenoid cavity or glenoid fossa is for articulation of the humerus on scapula, acetabulum is for articulation with the femur. So the head of the femur, change the color for that. The head of the femur, which is pretty large, articulates here. So that makes this the lateral end. So can you tell me, just by looking at this, is this the right os coxae or is the left os coxae? If that's the anterior end,
Right.
that's the right. Okay, so basically you are looking at all of this. This would be the anterior end. This would be the posterior end. So basically identifying this acetabulum and looking at the, so I try to take the pictures as if you are holding the bone. Looking at the bones together, now things will start making sense because we have structures like anterior, superior iliac spine, posterior iliac spine, iliac crest, sciatic notch, okay. Anterior, yes, posterior, superior iliac spine. So iliac crest is a tough ridge border. Iliac crest is this border, this ridge here. Okay. Then anterior, superior, and posterior, superior iliac spine. Now that we know this is lateral, that's anterior. Spine here stands for a protruded corner. Unlike scapula, where the spine actually emerged from the body of the bone, here the spine is basically the edge of the iliac crest. So anterior superior iliac spine, right there. Anterior, because that's the anterior end. Superior, because if we number this as 1, 2, the superior iliac spine. Of course, then what would we call? I'm going to erase this lateral right in here. What would we call this number 2?
Anterior inferior iliac spine.
Exactly, anterior inferior iliac spine. So basically identifying the acetabulum, the pubic symphysis, the obturator foramen, the 3 structures that I have right on under B, ossa coxa. I have them first because identifying these 3 basically gives you the location of the turning of the bone, how it would be turned. And now you can start naming crest, anterior, inferior, anterior superior, posterior inferior. So now, of course, what do we call? What would we call this edge then? What would we call this edge?
Could
Actually, it's
you
not
use
just
a different color? I don't think we can see where you're drawing it.
you don't see the yellow, this yellow that I just marked 2 lines. You don't see that?
I do see that now. Sorry.
Okay. You know, the yellow against blue is actually very prominent, which is why I'm using the yellow.
It hadn't been
So what
showing
would
up
we?
before.
Sorry, what's that?
It hadn't been marking, maybe. It just actually wasn't showing up on our screens.
Oh, okay. Okay. But it's showing up on your screen now, right?
It shows up, but it can kind of show up a little bit after, like it's lagging.
Oh, there's the lag, I guess. There's
Yeah,
the
so
zoom lag. Usually that doesn't. There's always something fun going on. Okay, you know, let me do this. Let me change my. Okay, tell me if that's any better. I'm writing the word better. Can you see that?
yeah, it showed up.
A little faster than before?
Yeah.
Okay, good. Okay, so here, spine, spine. Actually, this whole thing is spine. Spine, spine. What would we call this? And what would we call this? Number 1, number 2. What's number 1?
Posterior superior iliac spine.
Posterior, superior, iliac, spine. And number 2 is then?
Posterior, inferior.
Exactly. So see, the point is, again, once you identify the landmark features, the anterior, posterior, for long bone, lateral, medial, it becomes much easier. And that's how you should learn things. You should not arbitrarily, too many students have seen them in class 2, pick up a bone and would just try to look at a picture and say, oh, this is this. Oh, this is this. Oh, this is this. And that, and that. Just assign names to random structures and then they try to recall from what they see in the picture. Bones are complex, yes, but once you break the code, so to speak, they are not that complex. So here, to break the code, you need to know the positioning. It's a complex looking bone, but it does have an anterior end and a posterior end. And that anterior and posterior end bilocation would be clear once you know what's lateral, which is acetabulum will give you, pubic symphysis will tell you, obturator foramen, that's, you know, may or may not. So posterior, inferior, iliac, spine. That gives us another structure, basically inferior to the posterior, inferior iliac spine. There's a notch right there, this notch. I'm going to change the color now. This notch. This notch is there to accommodate the sciatic nerve. The sciatic nerve is the longest nerve in the body that runs from the gluteal area to the bottom of your feet. So this notch is referred to as greater sciatic or sciatic notch. That means there's a lesser sciatic notch. We just don't have it on your list. But FYI, this is known as lesser sciatic notch. So basically, this is what we are learning from the Osgox say. Okay, something else. True pelvis versus false pelvis. So I just have the bone turned in different ways here, just to show you again that how it will articulate, how the iliac crest is, what the iliac crest looks like. See how it's really like a ridge, iliac crest. You can clearly see the anterior, superior iliac spine. You can see the anterior, inferior iliac spine, acetabulum. You can see the pubic symphysis. And if we arbitrarily cut this in half, this is pubis, this is ischium. So you should learn it from the different turn.
I have a quick question, Professor.
Yes.
So that first image we were looking at where both we can see the ilium and the ischium and the pubis, that's where it's looking at it directly into a anterior view. Am I correct on
Yes.
that or wrong?
Like,
Okay.
and anterolateral, so to speak, because you see the acetabulum. Just a full anterior view would be like here.
Okay.
Yeah. This
Thank
is how
you.
it is. Yeah, this is anterolateral. This is also anterolateral. Basically, this you can say almost like a posterior view. You're looking at the interior, inside of the os coxae. So here is the sacroiliac joint, the surface for sacroiliac joint. It's not on your list, but you know, in case you are wondering, that's a rough edge. You can clearly see the iliac crest here, how it's really like a crest. It's raised, it's rough. You can see the pubic symphysis. Pubic symphysis is the first thing you should identify, because that basically tells you where is the symphysis, that's the pubis. All right, so we got pubis, we got ischium. And we got pretty much all of that is ilium. Yes, ilium. Make sure the ilium spelling is right. If you spell it as like this, you'll get 0. Normally the deviation as my spelling, you have looked at the spelling rubric. If it's just instead of an A instead of E, just a single deviation doesn't cost point unless it stands for something else. So if you replace I with E, this becomes part of the small intestine. So make sure ilium is spelled with the I, not with an E. Something else, true pelvis versus false pelvis. So when we say pelvis, basically, both osa coxa together, but also, especially when it comes to females, pelvis is also, this dictates some other factors like how much vaginal space there would be. So what is the vaginal, and how much problem a woman might encounter during childbirth, the positioning, how, not so much how antiflexed or retroflexed the uterus is going to be, but how much the uterus can expand, etc. So true pelvis and false pelvis. This terminology is used for mostly for females. Okay. So true pelvis is the space between the two os coxae. So here to here, basically this is the space between the two os coxae. This is what we refer to as true pelvis, the true distance. False pelvis, on the other hand, is the distance between the two ilium only. There's an interesting story that goes with it. In ancient times, when, maybe not that ancient, when there are lots of arbitrarily random things were assigned to females and their reproductive capacities, oftentimes it would be said that a woman who has wide hips is very fertile, will bear multiple children. Back then, bearing children was multiple children was a necessity, agrarian society, etc. The more, the merrier. So the wider the hip the woman has, the more fertile that woman will be, assuming that, oh, that means she will have no problem with childbirth, she will survive the childbirths and have multiple children. Oftentimes, that was a very wrong notion, because this is what we see, this is what we do not see. So just because the distance between two ilium gives a broad, wider hip, so to speak, from a naked eye perspective, doesn't mean that the distance between the two ischium area is also wide. It may or may not. So the true and false pelvis actually stemmed from that thinking. Just some of the interesting history of humanity. Anyway, questions?
Is the this might be a dumb question, but when you're like feeling your own hips, is that the ilium right there, those protrusions on both sides?
Exactly, yes.
Okay.
Yes. And unfortunately or fortunately, there's no way to feel your own ischium. However, if you sit on the lap of someone and sit with your, one leg on top of another, which tilts the os coxa in such a way that the person whose lap you are sitting on with one leg on top of another, they would definitely feel this. Most people would say, oh, honey, that hurts. Can you get up, please? Or maybe in a nicer way, but basically that's what it would be. So yeah, you can't really feel, you can, if you go through the gluteal area and you can kind of feel this, the ischial spine. But yeah, when you're feeling your own hip, basically it's the ilium is what you are feeling. Okay, so that was probably the hardest bone of the pelvic girdle. Hardest meaning most difficult, just because it's the way it's turned. Long bones are pretty simple, breeze actually. So the next bone that we're going to talk about is femur. Femur is the largest bone, not only longest, the heaviest bone of the human body. Femur bears most of the weight of our torso, which is why femur is also a bone. And when we talk about bone physiology, you will learn this. Femur is also the most dynamic bone, so to speak, because our bones, although this is just a glimpse into the physiological aspect of the bone, when we look at bones, they seem very solid, very white, very dead, because we tend to associate life with pink. Whatever looks pink, like muscles look pink, or we think they're alive. Blood, oh yeah, that's what we call alive, meaning changeable, etc., responding. Actually, bone tissue is a lot more responding than many other tissue in the body. Bone tissue can be used for diagnostic and is used for certain types of diagnostics, because bone tissue will quickly reflect what's going on with your life. Like your lifestyle. Are you a sedentary person? Are you an active person? Do you smoke? Do you drink, or do you not? Okay. It will also reflect what's your diet like. Do you have enough calcium, enough phosphate in your diet, or do you not? And have you been exposed to heavy metals or not? So many things are reflected by the bone, and the more weight bearing the bone is, the more dynamic it is, meaning the more changeable it is. So When you look at femur, it looks like a very heavy, very dead bone. But in reality, femur is constantly, every few months, the femur is reorienting its osteons based on which direction the stress is coming from. The distal end of the femur, this is almost every couple of months. This distal end is constantly, this is totally remodeled based on what are you doing at that point in your life, your diet, your exercise, your activity level, and your habits. So looking at, so I've given you the names here, and some of the names for the arthroses are here too, like the fovea capitis. So looking at that, the anterior and the posterior aspect of the femur. How do you know which one is anterior and which one is posterior? Basically, the anterior and the posterior aspect of the femur will be clear by looking at, first let's identify the head area of the femur. And that's something else. So looking at this, notice what the posterior surface has that the anterior surface doesn't. Okay. So the head of the femur is this nice, round, smooth part, the femoral head. The femoral head on the anterior end as well as posterior end, there are two protrusions. The protrusions are huge. So instead of calling them tuberosity or tubercle, like for humerus, we had greater tubercle, lesser tubercle. Here, the protrusions are so large, they are given a different name, trochanter. Greater trochanter, lesser trochanter. And there is just like there is a crest in ilium, a raised border, a raised surface, there is a crest between these two trochanters that's only visible on the posterior end. This crest, intertrochanteric crest, identify that, and you know the anterior aspect and the posterior aspect. Intertrochanteric crest is only visible on the posterior surface when you are looking at the posterior aspect of the bone. So when we transfer this, you can clearly see there is a crest here. There is no crest here. So the head of the femur, the neck of the femur, the greater and lesser trochanter, this is what you should identify first. Head of the femur or femoral head. Neck of the femur, of course, the constricted area is the neck. We learned that for humerus. Femoral neck or neck of the femur. Then you want to identify the greater and lesser trochanter. Greater trochanter, these two. Lesser trochanter. Now, do you see the crest? Do you see a raised surface connecting the two trochanters? If you do, this is the posterior aspect. So yes, we do see that here, but we use a different color. Actually, white and yellow don't go well. Yep, that is the intertrochanteric crest. Intratrochanteric crest. Okay. What else can we see here? Now, as we know, the direction of the head. Okay. Then we know again, just like for humerus, we knew the lateral and the medial. This is what goes into here, acetabulum. This is where the head of the femur fits in. So the acetabulum will have to be right here. That means this is the which aspect, which side? Head goes with medial. So this is the medial aspect. This is the lateral aspect. Now we can safely name the medial and lateral epicondyle and condyles. Condyles, basically the articulating surfaces, as we learn. The condyles of femur are visible on the posterior aspect, not on the anterior side. So what we have, medial and lateral condyle, we are looking at the posterior aspect of the bone because we identified this posterior intertrochanteric crest. Head side is the medial side. That makes this medial condyle. That makes this lateral condyle. Identify the condyle, then you know the epicondyle. Epicondyles are above the condyles. So medial epicondyle right there. Lateral epicondyle. How about the bone from the anterior view? Can we see the medial and lateral condyle? No, of course we don't. Do we see the epicondyles? Yes, of course. Right there. Medial epicondyle. Here we see the lateral epicondyle. Something else. We see a structure on the anterior aspect only, which is that patellar surface. So basically the patellar bone, which is a sesamoid bone, meaning it grows on a ligament. This is the patellar surface. Kneecap, what we call our kneecap, basically that's the patella. This is the patellar surface. This is where the patellar bone will go, like this. It's a triangular bone. I have a picture at the end. Actually, no, I have it right here. Basically, that's the patella. Triangular. Patellar surface. Something else that we see on the posterior aspect only is what's called the linea aspera. Linea aspera is a ridge-like line, not rough enough or raised enough to call it a crest, so it's called a line. Serves as attachment of multiple muscles. Large muscles, some of the largest muscles are inserted into the femur. Where is that linea aspera? You can actually see that line going on. There are different parts to the linea. We are just learning the main structure. Linea aspera right there, see that. Linea aspera. Did you get that? Now I got a single femur here. You can see the same structures here. Femoral head, femoral neck, greater trochanter, lesser trochanter, intertrochanteric crest. You can see the linea aspera, which means this is the posterior side. Crest, linea aspera. Where are the condyles and the epicondyles? Well, right here. Head side, medial. Oh, no, that really doesn't work very well. Medial, condyle, lateral, condyle, medial, epicondyle, lateral, epicondyle. And then here it is. You can see the anterior aspect. Same structures. No crest, no linea aspera. Patellar surface, no condyle, but yes, epicondyles are clearly visible. Patellar surface. And I have some that just kind of focus on the intertrochanteric crest, etc. Questions? What do I have for tibia here?
Can you see the patellar surface only when we're looking at the bone anteriorly, or can we see it on
Yes.
both? Okay.
No, anterior, because patella is only on the anterior side. Okay, so the next. So again, understand just like radius and ulna, you want to know which bone is medial, which bone is lateral. Not just for this. In 145, we are actually going over blood vessels. And later on in 145, when you learn the blood vessels, you will actually see that many of the blood vessels are much easier to remember if you know which one is on medial, which one is lateral, because they are named after the bones. Anterior tibial artery, posterior tibial artery, fibular artery. All three in vein, anterior tibial vein, posterior tibial vein, femoral artery, femoral vein, radial artery, radial vein, ulnar artery, ulnar vein, subclavian, below the clavicle, artery, subclavian vein. So understanding the bone not only works here, but also understanding the blood vessel, naming them. A lot of the blood vessels are named according to the bones because they are running parallel to the bones. So tibia is the medial bone. Fibula is the lateral bone. So you're looking at the right leg, you're looking at the left leg. If you remember that, then the malleolus becomes easy. So our ankle, basically our ankle part, if you feel your ankle, there is a flat lateral surface and is a flat medial surface. That's what basically what the ankle feels like. You can palpate, meaning move it with your hand. You can palpate with your hand. There is a pretty clear lateral flat area and a large medial flat area, right where your ankle is. Okay. Those flat surfaces. Basically, those are processes, long protrusion. And the process is called malleolus. If you remember that, then medial and lateral malleolus will become easy. Medial malleolus. Of course, tibia is the medial bone. It's the first thing I'll identify in the tibia by malleolus. The head is, of course, the head of the tibia is very clear too. So this is the medial malleolus. That makes the lateral malleolus. Which is not part of the tibia, but rather the fibula. So medial malleolus, lateral malleolus, it gives you the orientation of the bone. What else can we see here? This is how the bones will stay in the human body. These are actual bone. Look at how the actual bones look so much better than the plasticky bone. These are the plasticky bones. I'm holding the plasticky bones. They're still one of the better one, but look at the actual bone. They're also from collection of places that have a lot more money than we do. So tibia and fibula together, head of the tibia, or tibial head. Tibial, do I have tibial tuberosity? Yes. So tibial tuberosity. Okay. Tibial tuberosity is visible only on the anterior aspect. See that? Tibial tuberosity. Okay. If you look at the plasticky bone, the tuberosity is a little more clear. Tibial tuberosity. What else do I have? Oh, lateral condyle and medial condyle, or you can call it tibial condylar. So medial and lateral. Now let's look at this. So we know that the tibia is the medial bone. This is the medial malleolus. So basically, the condyles are better visible when you are looking at superiorly, meaning looking at the top of this, but we can say the surfaces here. So this would be the medial. You can either call it medial condyle of the tibia, or you can call it medial tibial condyle. And you can call this lateral tibial condyle. This is how the tibia articulates with the femur. Did we get that? This is just to show you a posterior view. So here it is. You can see how the femurs condyles fit into the tibial condyle. Basically, this is where we're just calling this condyle, but right there, see. This is where the condylar surface is. It's not on your list, but keep it as a reference. If you are looking at the posterior surface, which tibia is this? Left or right?
Right.
Why? Tibia is the medial bone. Medial malleolus. Imagine this is someone is standing and looking at their bones from behind, posterior view. If this is medial malleolus, the lateral malleolus will have to be on the other side, yes. Meaning the fibula would be here. That's the medial bone, that's the lateral bone. This is the left tibia. Tibia is the medial bone. Tibia is the medial bone. If it was right, then this is the right side. Medial malleolus. This is why I was saying medial malleolus. If you know the medial malleolus, it's much easier to identify left versus right. This is the interior of the ankle. That's actually this. Basically, this is the interior of the ankle. Tibia anterior view. Medial malleolus. Which tibia is this? Left or right? Which tibia is this? Left or right?
The right one.
The right, yes, because this is medial malleolus, meaning the lateral malleolus will have to be here and the fibula will have to be here. That's the lateral, that's the medial. You are looking at anteriorly, so it's the right tibia. It's just again tibia. So did you get that? Hold on a second. Okay, so fibula. We did take a picture of the fibula. Yeah, I think my fibula pictures had lots of glare. So the only fibula picture that I have is with the tibia here, right there. Fibula is pretty straightforward. We only have head and lateral malleolus, right? Okay. So medial view, meaning the tibia will be here as if you are looking by removing the tibia. You're looking at the bone. And I like this view because it shows you the malleolus. You are looking at the interior of the lateral malleolus. So this is the head of the fibula, which is a little, what would I say, a little more obtuse as opposed to pointy. And lateral malleolus, the distal end. Lateral view, meaning tibia will be behind We are looking at the lateral side. This is what I mean by look at the head is kind of obtuse as opposed to the distal end, kind of pointy. Lateral malleolus, fibular head. And when it's together here, same here, you can see. Fibular head, obtuse, lateral malleolus. So basically femur, tibia, fibula. These are our long bones for the lower extremity. Then we got the tarsals. So out of the tarsals, I have calcaneus, talus. Oh, I do have cuboid and navicular. Okay. So let's look at it integrated first. This is a nice picture that I found. Calcaneus and talus. So basically, tarsus. Tarsus stands for the bones that make up our heel and the very first part of the plantar arch. Okay, so our sole of the feet, very first part of that, and the heel area is made by the tarsal bone. Just like wrists are made of carpal bones, here the ankle and part of the sole are made by tarsal bones. So the tarsal bones, excuse me, there are 7 tarsal bones. Out of the 7, the 2 heaviest ones are typically studied more because of, fracture, bone spur, damage to the joint, etc. Typically, involves the 2 larger bones. The 2 larger bones are the calcaneus and the talus. Calcaneus is what makes up your heel. Talus is what makes up your ankle. Talus articulates with tibia. So calcaneus, as you can see here, calcaneus, talus, these 2 are the, calcaneus is the largest bone, it's pretty heavy, and then followed by talus. And then navicular. The navicular is almost looks like half moon, which articulates with talus. Navicular. Cuboid, as you can see, is the lateral aspect, articulating with calcaneus, cuboid. And then there are cuneiforms. If we transfer that now. I don't know if you can separate the calcaneus from the talus in this one. I can. Calcaneus, talus, half moon, navicular, cube-like, cuboid, cuneiforms. And here it's slightly separated. Again, if you go by the shape, so you are looking at from the inferior view. We are looking at the calcaneus. Talus, see the smooth surface. This is where the tibula articulates with. I spread it out a little bit so that each bone is visible. Otherwise, it's kind of together like this. But know it by the shape. Once you know that this is the heel, basically that's where your heel will be, calcaneus. This is where the ankle will be, talus. Articulates with talus, half moon, navicular. Articulates with calcaneus. Cuboid, cube-like. And then of course the three cuneiforms. I'm just going to use a different color for them. Three cuneiforms. Then much of our plantar arch is made by the metatarsals. Just like our palm is largely made by the metacarpals, our arch is largely made by metatarsals. So we got this. Let me use a different color. Bench. This. These are the, of course. Oh, that's a pretty color. Metatarsals. Then we got the phalanges again. Same thing, proximal, middle, distal, proximal, middle, distal, proximal, middle, distal. That goes for any of these. So our toes are made of the phalanges. So that's pretty much completes the entire skeletal system. We went over the skull, the rib cage, the vertebral column. Then we went over the pectoral girdle, clavicle, scapula. Then we went over humerus, radius, ulna, carpals, metacarpals, phalanges. And today we covered the pelvic girdle, the femur, tibia, fibula, the tarsals, the metatarsals, and phalanges. Do you have any question? Okay, so we have a little bit of time. So I'll answer questions. And if we need to go over something else, like some of the previous things that we covered, we can do that.
Are we going to be looking at any articulation points on the patella itself?
On the what again?
On the patella?
On the patella? No, just the patella as a bone.
Okay. Okay. Thank you.
Yeah, this is what I usually tell the students, you know, when I taught this. I haven't taught this lab since I was chair. I did not teach this lab for 10 years. But before that, typically the bone list will come up and many students will say, oh my God, it's such a long list. And I would say, compare it with the structures we are not learning. That's twice as long. Something to be happy about. It will be wonderful to go over every little thing, but again, I'm just using my best judgment to cover more of the general parts that everybody at some point in their career is most likely to encounter. Okay, are there questions that I can answer? Or do we need to go over anything that we previously have gone over?
Could you go over the lumbar vertebrae again?
The lumbar vertebrae.
I'm a little confused on the facets.
Let me stop the share right now of this one. Hang on. Okay, yes, stop share. Close this file. Vertebral column, axial skeleton. Where is that? Oh, right there. Okay. Okay. Did anybody get this? Everything about skull? That part? Did anybody get that?
Yeah, we got that.
What is that?
The axial skeleton?
There's more. There was a group called Everything But the Girls. So it's everything but the skull. Yeah, it's not just the obvious anatomy. Tried to put a little more humor in there to see if anyone got that. Okay, so axial skeleton. Lumbar vertebra. Okay, so lumbar vertebra. Again, lumbar vertebra is recognized. You know, it has all the specific, all the parts that a vertebra has. So let's first identify those. Centrum of the body. What do I have here? Body or centrum? Centrum. Okay. In the textbook calls it body. Centrum. Spinous process. That's the first thing two things you want to identify is the centrum, which is basically the anterior aspect of the vertebra, and the spinous process, which is toward the posterior aspect. Knowing the centrum and the spinous process basically gives you the location of the pedicles and the laminae, the transverse process. Okay, so now you know this is the anterior, that's the posterior vertebral spine. That makes this two transverse process, together processes. Pedicles, as we know, pedicles are the extension from the centrum. So extension from the centrum. Pedicles, this and this. Laminae are extensions toward the spinous process. So laminae lamina, if you're just referring to one. Then vertebral, vertebral arch. No, I just have foramen. Okay. So vertebral foramen, vertebral foramen. Then the superior articular process and inferior articular process. Superior and inferior articular process for lumbar vertebrae are slightly turned. It's curved almost. Okay. So what we see from the superior view, the superior articular process and facet. So process, use a different color. Process, what's number 6 here, basically? The process. This is superior articular process or processes, if you are referring to both. Instead of the facet being projected superiorly, as it is for thoracic vertebra and the cervical vertebra, the facet is turned interior. Because look at the processes itself turned slightly at an angle. It's not coming up straight. So the superior articular facet is turned toward, you find that toward the facing the spinous process. So this right here, number 7, is superior articular facet.
So just to reiterate real quick, the facets of the lumbar vertebrae face differently than the thoracic.
Thoracic and cervical.
Okay.
Because of how they articulate with one another. These articular facets are basically to articulate with other vertebrae.
Okay.
Yeah, just the way the lumbar vertebrae are shaped, they have to bear, again, the same thing. Lumbar vertebrae bear most of the weight, body's torso weight, okay? So the articulation between the two lumbar vertebrae are slightly different. And that's what dictates where the articular facet is going to be. For an average thoracic vertebra, the articular facet is just right there, as if the bone has been cut in half. Here, the lumbar vertebrae, the articular facet is as if the process is turned and the medial side is cut. I don't know if that makes sense, but it's like you have a, let's say you have a block of wood. For the thoracic vertebrae, etc., the superior or the inferior facet is as if somebody cut it right on top. This is where the facet. Here, as if somebody curved the interior part of the wood, which is why the whole direction of the facet is different in lumbar vertebrae.
For the purposes of the upcoming exam, are we allowed to type like abbreviated superior like you're writing on here, or do you want us to type out fully superior?
I would like to have the full superior inferior.
Okay.
I mean, if let's say you end up getting lab questions are also going to be from pool. So Canvas is going to randomly pull from a question pool that I'm setting up. If you get, let's say, 5 superior or 4 superior something, and the first couple of times you write superior and after that you just put sup dot, abbreviated it, I can understand that. But I would like the full name. It's much more helpful to, when you are learning it, it's much more helpful, at least I found. It's much more helpful to have the whole name. So now the same lumbar vertebra from the posterior view here. In the posterior view, still the same thing, centrum, you can see the centrum. We can see the laminae. You can see the transverse processes. You can see the superior, number 6 basically, the superior articular process. Number 7, you can see the superior articular facets, vertebral foramen, right there, number 4. Spinous process, number 2. Okay. Oh yeah, pedicle, laminae had a number 2, number 3. Okay. Then inferior articular process. Basically what they're showing as number 8 here is inferior articular process. Inferior articular facet is not this arch, but yeah, you can't really see that. It will be this cut surface here. Not the arch, but the surface. It kind of shows here. So this turned inward, turned facet, wide body. This basically gives away the lumbar vertebra, as well as the absence of transverse foramina like you see for cervical vertebra. Spine is straight out, not projected inferiorly. It's rather straight out. Heavier body, compare the body of an average lumbar vertebra with an average cervical thoracic vertebra or cervical vertebra. And the turn process and the facet. This basically is a giveaway. What else? Are there questions in the chat that I need to answer? It won't let me bring up the chat. So if someone can convey that.
Someone's asking if we will be tested on skin.
No, integumentary system, in a face-to-face class too, I typically don't cover integumentary system. I have it there in the manual because some faculty requested it. These are a little too unique, for a unique profession. I mean, I can answer questions if anyone needs. Yes. What's the question?
Before you had mentioned that you'd like us to be able to identify the difference between different tissues. And I
Yes.
know that on the exam, there were some questions like that, but there were no images shown. Are you planning to test us on that as well?
Well, the lecture exam did not have any image because it's not anatomy. I'm not trying to identify. I'm giving you characteristics. That's what I did in lecture exam. Yes, but anatomy exam is all visual. Yes. So it mimics as if in a face-to-face exam, you look at the microscope. Here, I'll show you the image and I'll ask you to identify different tissue and if there are structures and things associated like collagen fiber, elastic fiber, etc. Lacunae, lamellae, things like that. Yes.
Thank you.
Someone
Okay,
asked,
there's a,
generally, how would you describe a facet? Is it just a concave area of articulation?
facet is an area of articulation, yes. It's not always concave. Sometimes it's just like a straight. Here for the lumbar vertebra, it is concave, but look at the thoracic vertebra, it's not concave. The term facet stands for angular, meaning something that's cut at an angle. That's how the word faceted beads, faceted, when people go to buy jewelry and there'll be description, faceted emerald, faceted diamond, XYZ, faceted XYZ. Facet stands for an angular. So what does that mean by angular? If you look at this here, the thoracic vertebra, basically you see what it means by angular. So this is the process. This is the facet, as if it's chopped at an angle. It's the process cut at an angle. It's not always concave. But yes, it's a surface, it's an angular surface for articulation. It may look concave, like in lumbar vertebra. It may not look concave or convex. May not, just an angular cut, an angular surface at an angle to the process. Okay, is there any other question we need to answer?
I have a question.
Mhm.
So I'm pretty sure you've answered this before, but I just want to make sure and clarify. So what is the format of the test going to be like? Is there going to be any multiple choice, or is it all going to be fill in the
No.
blank?
It's all identification. Live exams are not multiple choice at all.
Okay, just making sure there's not like any like real, I don't know, physiology to it.
No, that's an idea though.
I was curious, I see on the practice exam
Uh-huh.
that we get 1.5 minutes for each station to total 23 minutes. Is that the same length of time as the exam, or will our exam have more stations on it?
If a lot more stations, yes, it's 100 point. And I'm also using color coded for the exam instead of arrow, because when the exam loads, I used arrow for one exam last semester, and when the exam loads, sometimes the arrows are not clear. So I'm going to use color coded. Questions. So basically, let's say, I'm going to draw something here. Let's say something like this. So number 1, name this structure. And then on the image itself, I have, let's say, almost as if we have stickers. The face-to-face exam, we have stickers. So I'm trying to mimic that. If I erase everything else, actually, you know what? Let me just, oh, it doesn't let me clear all drawings. So I'm just going to clear everything from here. Okay. So let's say I have 3 questions. I'm still making the exam. I just started. So I'm not sure if I'll have 2 or 3. I'm inclined to give 2. If there are 2 questions, then you'll have time and half. If there are 3 questions, you'll get 2 minutes per stations. And I'm inclined to give you 2 questions per station. So each one is a station. Each image is like a station. So let's say, actually it won't be in pink. It will be more like typed out. Name this bone. Name this structure. And then I have yellow sticker. and I have blue sticker. Okay. And so name this bone, I have, not blue. Let's say yellow stickers all around. Meaning the entire bone has to be named. In that case, your answer will be
Lumbar vertebrae.
exactly lumbar vertebra. And then for the blue, I'm saying name this structure. Let's say I have, along with the yellow dot, I'll have, I have blue. And I have blue dot here. So you go this structure, okay, blue with blue. What would be those answers then?
Transverse process.
Transverse processes. Yes. So it will be image like this. And below that, there is a space where you have to basically type number 1, like the practice exam number 2. But instead of arrow, I'm making it color coded. So that is a little clearer. The practice exam is made in haste, and I imported some questions from. But color coded, I like the color coded idea better, because then there is fewer mistakes. There are fewer mistakes by students in switching out answers. You know what I'm saying? If everything is arrow, 1 arrow, 2 arrow, then sometimes answers get switched, especially when you're anxious. Color coded clearly tells you this for this, this for this. What else? We have 15 minutes. Are there any other questions I can answer?
You said you were going to send out the access code for the quiz today, or you were going to look into it? Or?
Yeah, I would look into that. There should not be an access code is what I'm saying. There should not be an access code.
Okay, great.
So I deactivated the access code, but if it's asking for one, then I'll just assign an access code and I'll just send it an announcement.
Okay, thank you.
I'm just kind of surprised that it's asking for it, because I unchecked. I checked first, then I deleted the whole access code, then I unchecked it. But who knows what. Okay, any other question? Okay, so I'll assume that there are no other questions. And so I'll stop the session. Let me stop the share first.